have noted, it's unusual for there to be more than usually the panel plus 2 or 3 people attending a session on reconstruction. So I'm hoping that you're all in the right room. And if you're not in the right room, I'm having the doors locked so that nobody can escape. Apparently the main session is running late, and they asked us to just go ahead and start at 10:30. So that's what we're going to do, and it's probably irrelevant since even if all those people try and get in here, they won't be able to. So if anybody wants to do like Uber or one of those other apps and sell your seat to someone that's in the main session, feel free to do that. Dr. Farwell over here will collect a 10% commission. But our panel today, and forgive me, we didn't really have much control over how the room was going to get set up, so there'll be a lot of craning and people turning around and looking around. So, oh, hey, Bevan. So I wanted to thank everybody for coming. Thank Dr. Bevan here, you for putting on a great program. Yeah, so squeeze in, be friendly. We're all friendly in the reconstruction field here. The design of the panel is going to be a little bit free-flowing. We're happy to make it as interactive as we possibly can, so feel free to jump in if you have any commentary or if you have any questions or you want to contribute anything. Then I'm Dr. Wax.
Peter Cordero from New York.
This is Peter.
Samir Kariwala from Minneapolis.
Greg Farwell from UC Davis.
Marcelo Figari from Buenos Aires.
So Marcel and I are going to co-moderate this. You've met the contestants. Dr. Chapea is, since he's going to be going up to Toronto and working with Dr. Ghislaine, I suspect that he's probably still in the presidential address, and he'll make it a little bit later. So if any bad results that you see, they're all Dr. Chapea's. The format. So from a disclosure perspective, I taught a course for Cynthes Dupuis. Probably won't ever teach another one because I think I spelt their name wrong here, and they paid me for that. Dr. Farwell has gotten these honorarium, and the other members of the panel did not have anything to disclose. And if there's anything that you think is too biased, then by all means report that up to the Head and Neck Society for our CME compliance. I always like to use this as a plug for the Head and Neck Reconstructive Fellowship out in Oregon. This is our Hood to Coast team, so you get to do reconstruction, and then you get to participate in a 200-mile relay from the top of Mount Hood to the Pacific Ocean, and you get to survive. So those of you that are interested, we're going to do this as a combination of presenting a couple of cases, pimping the panel, asking what their view was, what they would do in these particular circumstances, and then after about 10 minutes, we'll turn it over to the panelists that submitted the cases, and they can give you their personal philosophy, how they would handle something and what their personal pearls would be. We have Dr. Chapea is going to cover a complex fistula. We'll just screen through this. So like every panel and every talk, it's all keyed to last exactly 15 minutes apiece, and everybody will keep on time. And as you can tell from the state of this room, already it's starting to degenerate. So the first cases that we were going to, Marcelo, did you want to say anything? Did you want to say anything by introduction, or?
No, I will co-chair with you, and at the end we decided with Dr. Wax also to present some personal cases in order to complete the organization of this table.
So our first point that we were going to talk about was flap selection for maxillectomy, and these cases come from Dr. Kariwala from University of Minnesota. And I'm not, so for the panelists, if you can crane your neck and look over and see, this is a gentleman that has a maxillary carcinoma. He's a 65-year-old schizophrenic. He lives in a group home. He has no family relatives. The question of informed consent. You know, he does live in the home. There is nobody that really has a power of attorney for him. You know, where do you draw the line when you're going to consider major head and neck oncologic ablation or reconstruction in someone from an informed consent perspective? Do you have a different threshold? Do you have the same threshold? I don't know why I'm looking at you, Greg, but you're up.
Well, these are obviously more challenging because understanding the nuances of what's required to remove that tumor and reconstruct that patient is challenging in a sane person. So I think these involve more people and more visits, but I don't necessarily let his psychiatric diagnosis dictate the extent of the resection or the reconstruction.
So do you, in someone that you can have a full and forthwith discussion and discuss the morbidity of a fibula flap and the rehabilitation of the leg and what the wound care is going to be, would you offer someone that could maybe not understand the outcome a lesser operation?
Well, on occasion I will, but I would flip that around, and you know, the implications of someone that's mentally challenged handling an obturator, being able to take a diet, I think is another competing interest here. So yeah, you take every patient as an individual, but I wouldn't let that necessarily determine the approach I have for him.
And then this is in fact what Dr. Carawala did. He did a temporal parietal flap. Should I be aiming this anywhere different or just up in the... and he did a temporal parietal flap with a obturator. So does the AV, am I supposed to be pointing it anywhere or just keep clicking and eventually something will happen? So temporal parietal flap with a obturator in this case, to obtain a pretty good and pretty functional outcome. So one of the other issues that we face in maxillary sinus cancer when we're looking at reconstruction is what do you do about the orbital floor? Peter, you're here. Would you? So if you had someone, you're going to take the orbital floor. You can see the invasion here with the red line. So you're not going to have to do an orbital exoneration. Do you routinely reconstruct the orbital floor? What do you do for the orbital floor?
Yeah, I routinely reconstruct. I think a lot of people feel there are things like Whitnall's ligament, et cetera, that may support the globe, but I think generally you need to put in something solid, and I like bone. I'll usually use cranial bone if it's a craniofacial exposure, or iliac crest. I'm partial to bone. I think you can use other synthetics. And then I will always cover that with a healthy flap. And I think I rarely will use an osteocutaneous flap for this particular indication. Bone grafts actually work very well as long as you cover it with a healthy tissue.
Anybody else use anything other than bone grafts?
No. I would say that in our opinion, the best option for orbital floor reconstruction is always the titanium mesh, because not only because of the predictable result, but also because this type of reconstruction will remain mostly exposed to the sinus area, so the titanium will offer a very reliable solution.
So have you found, we use a titanium MedPort implanted with titanium mesh. I mean, it's they're all pretty much. But if you don't get complete soft tissue coverage, then we've had a very high extrusion rate. Yeah. So unless we put up a soft tissue flap and to completely cover the implant, we're oftentimes seeing those implants 9 months, a year later. Has that been your experience?
Yeah, of course you try to cover always with biological tissue the implant, but even in the case you have some part of the mesh exposed, the reepithelialization is very nice. And you don't see cases or frequent cases where you need to remove the mesh. What do you think, Greg? I think it's your experience also.
Yeah, I've had great luck with mesh alone, but adding the porous polyethylene without vascularized coverage, I think, has created more problems. So if I'm going to use an alloplast, which I do in most cases, I use mesh, and I don't worry as much about the mesh not having an inferior vascularized coverage.
So we oftentimes will compromise our bony reconstruction of the maxilla in order to get good soft tissue reconstruction. So we'll put up a fasciocutaneous free flap, whether it's something large, to make sure that we're covering our implant, versus putting up a fibula because I can't get it to give me the soft tissue coverage. And I'm going to take all the nodding as people think that's
Would absolutely
something
agree with that.
reasonable.
I'll just add one thing, since this is my case. I agree with Greg's points. Part of the reason I included this case is because I'm not sure that I necessarily did the right thing for him. I wasn't sure that I could adequately consent him and counsel him regarding the reconstruction, let alone the maxillectomy. And so I chose to do something simpler in the initial part and offer him a chance for secondary reconstruction if he chose it. So far, he's doing okay with that. As far as the orbital floor reconstruction, I choose to put TPF underneath these mesh reconstructions, especially in the indication that the patient's going to get radiation, in which case I really don't want to see that mesh, and I'm not sure that's going to epithelialize after radiation, and it's been very good in that regard, and I haven't had mesh exposure.
Okay, so part of what we've done is I have a large number of cases that, and as the discussion goes on, we'll probably click through some of them just to keep on time so that we can keep up. But if you see something that you really want to hear, just yell, throw something. And so I'm going to just proceed on to Dr. Karawala. He's going to give us a little talk on the flap selection for maxillectomy at this time.